Right, it seems that you do have my slides. So first I would like to thank Shirley very much for inviting me. It's always a pleasure and honor to participate to this event. Very agreeable, very nice setting, but also very interesting event. I'm going to talk about surgery, a topic I know that you're interested in on a daily basis. But sometimes I understand as well that sometimes you may be afraid of surgery, and we are going to discuss new technologies applied to surgery. Before I start, a few disclosures. I invented a device which I'm going to present in this talk. The name is SynpiciTI, and also I am a speaker for those labs. When we talk about orthodontic surgery, we are used to planning, simulating those cases. We also manufacture guides. This is what we call the gold standard. So what we do is use a Facebook to register the patient's anatomy, then we do a mounting in the articulator, then we have a stone model for surgery, and then that way we have a very rigorous, very stringent planning to plan a very good surgery. Fact is, it's not always the case. We may have a number of errors when we analyze the patient's anatomy. We mostly work with 2D radiographs, and you know from experience that a Facebook you may register on a Monday, but then 2 days later you do another Facebook registration. You may have many gaps in between the registration, and if you have 2 different operators, then you're not going to have the same registration either. So it's very difficult to be certain of the accuracy of this registration, and of course it's not possible to superimpose your registration and the result of the surgery. And we know that in between the teleradiograph and the registration, we have differences in the occlusal plane. You can see here, you have a graph, a different patient is represented by a different bar, and you see that there are a number of rotations in between the occlusal plane on the teleradiograph and the articulator. So there are many degrees of difference, ranging from 6 degrees to up to 15 degrees, and of course 15 degrees, I let you imagine how severe the consequences may be on your surgical result. So all this to say that today we have other tools, other contraptions, and of course digital tools that help us plan our cases in a fully dematerialized environment. So we can visualize the result of our indication, how the bone is going to remodel. We can choose the best fitted scenario, and from a 3D simulation we can directly print guides or splints that are going to be used during surgery. Now the protocol is a lot more accurate in that we have a pseudo-real anatomy because we plan based on a scan. Now, of course, we need to register the mandible mobility of movements, but we are a lot more accurate. Obviously, when we reposition our both maxilla, we know that we have to reposition the mandible properly compared to the upper maxilla. Now, this has been studied. It may look a bit disappointed. Again, each bar represents a patient. On the one hand side, you have the repositioning with conventional articulator model, and on the right hand side, you do have virtual planning. And of course, you do see that we have the same level of accuracy or the same lack thereof. So inaccuracy, irrespective whether you use a conventional articulator or virtual planning of surgery. So it's not that better. And so at the end of the day, what really matters is how you reposition the mandible perioperatively. If you start with an osteotomy in the maxilla, you know that the mandible is going to be mobile, and so this is where the heart of the matter really lies. Therefore, we try to change this approach, and we try to reposition the mandible based on a bone milestone. So based on a milestone, on an indicator that would be based at the basis of the score. This is a paper of 2010, and this, in a way, what we have developed is nothing but a reinterpretation of the same principle. And basically, you need to know what are going to be the osteosynthesis plates that you're going to use. So that is a simulation phase, a design phase. We go from left to right. This is the digital workflow. So we simulate the surgery. We create a mapping in color whereby we know on that map how thick the bone is. This is very important when you want to place your osteosynthesis screw. And once you know where the screws are going to be positioned, you decide to place the maxilla in the right position. And starting from that, we design a guide, and through that guide, we are going to drill the holes for the screw. So the workflow, the surgical workflow, is going backwards. We start by the drilling of the screw holes, osteotomy plate, and repositioning. Perioperatively, it just looks like that. Surgery is not so much different in terms of technique. The same devices are used, the same instruments. We start with the guide, then again we follow the markings on the guide, we drill, we perform the osteotomy, but then the maxilla is not repositioned based on the bite, but through the insertion of the grooves in the pre-drilled holes. Now the question, of course, is that, well, are we more accurate thanks to this new workflow? And this, of course, requires a study, which we performed. And on a series of 80 patients, 60 Lefort osteotomies in one block, monoblock osteotomies, we have an average accuracy on the inter-incision point and at the level of the first molar. Well, we have an accuracy, or a lack thereof, of less than 1 millimeter. So it's a lot better than a conventional workflow or digital workflow, digital planning. Now, of course, the mean is important, but there may be a very high standard deviation. Here, standard deviation is actually not very poor, and quite the opposite. You see that the standard deviation is limited, and it's less than 1 millimeter. Now, this being said, you see that there are a few outliers in this result, so a few patients for which the result is not good. So very few cases, very few and far between, but over 60 Lefort 1, there were also Lefort 1 segmented, and it seems that when you have a segmented Lefort 1, the fragments are smaller and you have more resistance. Now, those outliers, we need, of course, to handpick, and it's usually when we need to have an anterior impaction, and we know from experience that it's very difficult to implement surgically, simply because when you want to impact the maxilla, sometimes in extreme cases, here you see the difference between the planned occlusal plane in grey and the result we got in pink. You see that there's a huge gap. It's the worst case of our series. And you see that the device also was not used properly and the osteotomy didn't go as planned. You see that the pterygoidian bone was cut during the osteotomy, which was not the case. We're supposed to have a posterior disjunction. In a way, of course, the bony interferences were removed, but the dissection in the pterygoidian bone was an issue, and this did not make it possible for the maxilla to get back to the original place. And it doesn't come as a surprise if eventually we didn't get the accurate result that we were striving for. So in segmented Lefort, we also have mean results that are rather accurate, less than 1 millimeter gap, and standard deviation are decent. Now, the question that this also poses, There's, of course, an advantage for the segmented osteotomies. This is mostly for expansion, and those are of the most unstable surgical maneuvers. And what's very interesting with this is that usually you need to have a retention device, very rigid, for at least 3 months, a palatal plate. Some will want a transpalatal arc or an occlusal plane, but in any case you need a retention device which is very rigid, and with that we have a very rigid contraption which makes it possible for us not to have a retention device, and which really help in rehabilitation when we want to deal and rehabilitate those transversal rehabilitation cases. So we make it possible to have decent proprioception, the palate is not covered, and it really helps with stability. And so, as expected, we have a slight relapse. You can see here that in between canines and molars, in between the foramens in the palate, there's a slight relapse between the immediately post-op and 1 year, but this is rather similar to what we see in literature when patients wear conventional retention, irrespective again of the type of surgery, surgical expansion, etc. So this is not very different, and so in this case of segmented osteotomies we do have a very clear advantage. Now, we are going to have a look at a few clinical cases. Asymmetric cases are difficult to manage, are difficult to tackle. First and foremost, it's also difficult to assess the asymmetry properly and then to plan surgery accordingly. And surgery itself is difficult to plan and execute in order to get the result which really fits the simulation. This patient, when you look at her face, you can tell that there's a level of asymmetry. You don't think that it's very extreme from the extraoral photographs, but when you look at the teleradiograph, you see the huge difference at the basis of the skull. There's a face scoliosis, which seems a lot more significant on the radiograph than it is clinically. So sometimes there's a not a proper assessment of asymmetry when you look extraorally. So this is, of course, a clear indication of a side teleradiograph in order to take into account the ear meatus, the orthostate as well. And when you have an asymmetry in the basis of the skull, you don't necessarily should base your sagittal plane or your horizontal plane based on the at the ear level. What you see here is that the ear meatus are not aligned, and so if you want to align them with an orthostat, you are going to have an impact on your plate, your vertical plate, which is going to be more oblique, and it's going to provide a poor rehabilitation of the symmetry. So you need to have a 3D assessment, which is really going to help have the right repositioning. So you do see here that we plan, of course, a centering of midline, centering of the chin. You can make as many measurements as you want. You also have those jaws that are properly symmetric after planning. Now, obviously, there's a level of asymmetry in the condyle levels because obviously the TMJs and the ear meatus are not aligned, so it's just fitting that they are not aligned at the end of the planning. But this is after surgery. You do see that symmetry is very nicely corrected, a lot more harmony in the face, and this was nicely predicted and executed. In those asymmetric patients, sometimes it's very difficult to get a proper repositioning of the condyles. And you see that on the left-hand side, spontaneously, the patient is spontaneously in propulsion. The condyle is really at the front of that joint. It's very difficult to find a centric relation in this patient. She had a condylectomy on the left-hand side, and so she compensates, but spontaneously being in a non-centric relation, and so we have a hard time pre-operatively to get the centric relation. Now, with this planning, we're going to simulate a better symmetry of both jaws, and so general anesthesia, of course, for this patient in order to get a complete relaxation of the muscle, so you get rid of all muscle compensations thanks to the general anesthetics, and we get a very nice simulation, and we get proper repositioning of both jaws. We can also be creative, and we can envisage more complex osteotomies. It's interesting for those long faces, but class 3, with an hypoplasia of the medium third. The deficit here is not only based on the jaw, there's also an hypoplasia under the orbital bone with a pseudo-exophthalmia in this patient. And so in that case, we can plan an osteotomy where we're going to provide the valgus in the zygoma, and you see that the contraptions that we use are rather bulky. It is a rather invasive surgery, and well, you may wonder if you're going to fit those instruments, but actually they do, and it's a surgery which is very similar to a conventional level 1 surgery, and this is the result that we get with an increase of projection in the at the level of the malabone, the zygoma. Look at the impact on the face, look at the zygoma. The impact is major, so more protrusive zygoma, and you see a remodeling. The eyelids are changed, the area under the eyes, which used to be very shallow and very narrow, or deep, rather sunken in, are completely changed. And so with that simple surgery, a rather simple surgery, again, which is planned upstreams, you get a very nice result. It's a surgery that you can do with or without a guide. Now, of course, when you reposition the zygoma on the one side, you need to place the zygoma on the contralateral side as nicely as possible. So you need to take measurements interoperatively. This is if you don't use planning. If you do use planning, you can be very symmetric. Now, we also have indications, other indications of this planning and of those guides. Well, it's probably something that we see very much in our expert center. I receive a number of referred cases, so patients who are sent to me for a second surgery because they had complications or because they were not happy with the first surgery. So I discussed asymmetries. In that patient, her main complaint is that midlines are still not aligned, and it's true that there's a deviation, and this doesn't come as a surprise. I told you before that the splints that we use perioperatively are not always very accurate. What makes matter worse for the patient is that the nasal pyramid is also very asymmetric, and of course it makes for a more difficult centering of the midline. So the nasal wall is not very symmetric, and of course should the midline be aligned with the tip of the nose or with the center of the nose, you see that there are also a lot of muscle spasms, and so we can anticipate all we can do thanks to this guide. When we plan those guides, of course, should we remove all the osteosynthesis plates that were implemented? Well, actually, the answer is no. I never had to go and remove the plates before I plan the subsequent surgery, except for one case, but it was a particular case. The first surgery was post-trauma, so there were plates virtually everywhere. But except for that very particular case, usually you do see what you get, and what is highlighted in red is the impaction that we performed. We also performed a genioplasty, which made it possible to impact the mandible, the maxilla as well, and we get a face which is a lot more symmetric, a lot more balanced, well, actually, in my eye. You also have other indications that may sound like an anecdote, but there are cases where we have a hard time finding the right treatment planning of a treatment option. And in those cases, in case of Brody, for example, with a type of scissor bite, this patient is typical of a Brody case, typical scissor bite, no asymmetry in the basis of the skull, but there are asymmetries, severe asymmetries in between the maxilla. They are very difficult to treat, very difficult to have them wear a fixed device. So we do a complete subapical osteotomy with an intrusion. And again, those are purely alveolar defects. So we do the osteotomy. This is an impaction osteotomy in order to correct the protrusion. Well, I apologize, by the way, for the poor quality of the photographs, but you see that eventually we get to class 1. We also have completely removed the scissor bite. This is an early phase, only a few months after surgery. There will be a finishing case, and I think it will go smoothly. Now, let's talk about those cases of vertical insufficiency on the posterior level, and we have a varied number of indications. There are different strategies when those insufficiencies are severe. There's no doubt whatsoever we should correct them. Now, when we need to lengthen a ramus, there are different advantages and drawbacks. What we would do an osteotomy in a reversed L shape. You have a very severe bone defect and you need a graft. Now, the interest with our approach is that we can optimize the osteotomy cut. So the cut is very much improved in order to get a very good bony contact at the end of surgery. And this is, we know, one of the prerequisites for stability of result. When you have this posterior lengthening, they may be very unstable, especially when there's a bony defect. This is another example. We don't always have to go for this reversed L osteotomy. Sometimes we can limit or maneuver to a more conservative approach. There's no condyle in this patient, but the joint remain functional. Now, of course, you may question those indications. I know that our Anglo-Saxon colleagues rather go for prosthesis, joint prosthesis. I don't really like those prosthesis in young patients because we know that those prostheses are not going to last for the entire lifetime, and if you need to reoperate to change the prosthesis once or twice, you're not sure what you're going to get eventually. So as far as I'm concerned, I try to avoid using a prosthesis in very young patient. So this patient is not painful. She has a decent function, and so I do not want to remove the entire joint per se. So I was able to do a sagittal osteotomy, conventional sagittal osteotomy. So this way I have a rather considerable advancement. Again, I apologize for the poor quality of those photographs. They were snapped maybe a bit too quick, but it gives you a very good overview, and we have a decent early post-op result. So in those cases, obviously, you avoid any loading of the TMJ. It's only for the photograph that we ask the patient to bite that way. So we try not to have any posterior occlusal contacts, and then the splint progressively is reduced. And this is the result that we got when the open bite was completely resolved. You see that when she opened her mouth, there's no functional issue, and she's not in pain, obviously. So in patients like those, I don't see any reason why we would sacrifice the joint. Now, you can't tell in that patient, but we have not increased the posterior vertical dimension, and this may be questionable. So what we do is really change the posterior angle, and what we can do, and I sometimes do that, is use implants that are going to recreate the mandible or mandibular angle. So as I said, with a proper cut, sometimes we have very nice bony bone-to-bone contact, sometimes it's just impossible, and so when you do not have a proper contact point, I'm going to use porous titanium implants. The mechanical properties are enhanced in order to have properties that are very close to those of the bone, so they osseointegrate very nicely, those implants, and thanks to that we can redefine the mandibular bone. Well, it seems that there are a few slides that went missing in my slideshow, but you do get the post-op result, and you see that it is very stable. This is 3 to 4 years post-surgery. It's a very stable result, no relapse of the open bite, and this was again a case where we had a condyle resorption. Those porous titanium implants are planned in 3D. You can also correct asymmetries. For example, in the case of this patient, hypocondyly with a condylectomy on the right-hand side. So we had a residual asymmetry, so mandible centering, and you see that the ramus on the left-hand side is very concave, and the patient is not very happy with that very hollow aspect of one of the cheeks. And for this patient, I decided to use this porous titanium implant, rather bulky but very well tolerated. This is 3 years post-osteotomy. The result is stable. The symmetry is, well, acceptable, and the patient is, generally speaking, happy. Occlusion is also acceptable. Now, there are cases when there's no occlusal indication, but sometimes there's a canting, and this patient, for example, is complaining about a smile which is very asymmetric. So the plane is relatively straight, but we improve the occlusion. The patient doesn't want to hear for orthodontic treatment, so this is the plate that I use. So I performed the resection of the basal plate, genioplasty, in order to have better symmetry, and I had a 2-part porous implant. Because, of course, the nerve is running right in between both parts of the implants, and so they do position very nicely, and again, thanks to the 3D planning, you have very accurate implants, very well tolerated, very well also integrated. Now, in a nutshell, if I were to conclude, I think I was able to show you that thanks to those technologies, you have 2 major advantages. In the planning phase, it's definitely an asset for all of those patients that are more complex. And of course, it's up to you to define how complex a patient is or is not. But I think it is a lot There are a lot of benefits to performing a 3D planning, to see, to visualize from an anatomical point of view how the results is going to look like. Also, technologies are very interesting for splints. We can improve the accuracy of surgery. And then for more complex cases, the guides, but also the implants, the customized bespoke implants are very good, very well accepted, very predictable results. They do help with surgery, those implants, and I think it's definitely an asset for our surgeons, especially when we go for more complex cases. So it's very good to have them in our armamentarium. There's a wealth of indications. I've just gone through a catalogue of those. I couldn't show you everything that can be done, but because of time constraints, I just had to limit to a few examples. And again, it helps with the planning. Of course, there's some planning time. There's a cost, of course, which of course also asks a question of usability and accessibility. But I think they are definitely an asset. I would like to thank you very much for your attention.